So we'll start with the first kind of basic talk from Dr. Renuka Iyer, who is actually coming from Buffalo. And I had the actually honor and privilege to kind of follow Renuka's career right from the beginning. And one day they invited me to Buffalo for giving grand round. And we were sitting, I think, for kind of like after grand round, just meeting with the faculty. And she looked at me and said, what shall we kind of, what shall I focus on? And I remember very clearly I said cholangiocarcinoma. And I don't know why I said that, but it seems that she heard it, and she's been really doing amazing work on it. And really now you're co-directing the center up there as well. And you saw all the nice work as well in building the apps, which is kind of like the birth chart from this meeting. Actually, if I recall, you were on that table 2 years ago, and this where kind of like all started. But anyway, so Dr. Iyer will tell us all about what bile ducts are, what bile is. It's kind of like start with some basics. I think it's a good idea to empower you with that information as well.
Thank you for that introduction. I'm very comfortable talking to patients, but I've never spoken to like 200 all at the same time. And Ghassan has this thing, I think it's Stacy, I don't know who makes the program. They always have me going and talking about something small after somebody really cool. So, not fair. But we'll talk about the bile duct, and we all know about the bile duct, but it's always kind of, when your child asks you like the most basic question, like why is the sky blue? And then you're like, okay, just eat your pancakes, I'll tell you tomorrow. So I forgot. And so that's sort of what this is like. I'm gonna do this. All right, so where does bile come from? It comes from the liver. And what is the function of the liver? What does the liver do for us? One of the things it does is make bile. And the reason why it does make bile is so that we can digest fat. I know some of us are secretly thinking, really? We don't even want it. But that's one of the jobs. And it turns out some vitamins are fat soluble. I mean, we do need to absorb some things that are in fat. And in addition to that, it has the ability, the liver, to clean the toxins. And some of those also get excreted into the bile. I tell patients, think of bile as Drano. Everything doesn't dissolve in water. When you want to clear out your kitchen sink with stuff, sometimes you just have to put it in something a little bit more robust. And the other things that the liver does for us are that it helps make factors that help the blood clot. It makes and stores sugar. And sometimes when patients have cancers involving the liver, if it's quite affected to a large extent, their body is not able to make sugar quickly, and sometimes their blood sugars drop. Just some random little tidbits of information. So where does this bile duct come from? When we came here for one of the previous meetings, there was a speaker that told us embryology, where do we all come from, the very first cell. And it turns out that the liver and the bile ducts inside the liver come from this one bud, which is the green portion, and the rest of the bile ducts in the pancreas come from the other two buds. And they merge as the body, develops and the embryo grows. And that's why when you get pathology reports, or some of you may have been diagnosed and they said, we think you have bile duct cancer. And I'm sure you hear that word and go, what do you mean you think? Don't you know? Why did you take a piece out and you still don't know? And it's because these cells look the same. They came from the same place originally. And so when we give a little piece to the pathologist, unless you tell him where exactly you found it, it's hard for them to say. So they just say it's of pancreatic or biliary origin, because that's what it looks like to them. They're all the same cell. And what happens is that, thankfully, when everything goes well, this pancreatic bud, these two buds, they rotate and they go and they become the pancreas. And that's what forms the extrahepatic bile duct. So really it's two separate buds from embryology that merge and make what is called the whole biliary system, which consists of the intra, meaning inside, hepatic liver bile duct, extrahepatic bile duct, and also the gallbladder, which is the place where bile is stored. So this is what the anatomy of the bile duct is. And most of us in med school start here because we kind of forget where all of this originates from, but it's helpful to know that. And so when you look at the bile duct, the intra and the extrahepatic bile duct, there is the right duct, the left duct, And they come to this point outside the liver and they merge. And that area is called the hilum of the liver. And at that point, if cancers develop, we call that hilar cholangiocarcinoma. And further down, below the point where the gallbladder drains bile, there's this little duct called the cystic duct. And where that meets the bile duct, below that, we call that the extrahepatic bile duct. And as you can see, the extrahepatic bile duct, also called as the common bile duct, which is because the right and left and cystic have all merged. Now this is the final common pathway. Kind of a little bit of a design flaw, if you ask me. You have such an important function, and everything's coming out of one spot, like really? And all of that even goes through the pancreas. And so sometimes patients with pancreatic cancer will develop a tumor in the head of the pancreas, which goes and literally does like a bull head banging on the bile duct and causes it to get obstructed, something that many of you may have experienced during the initial part of your diagnosis. So this is that final picture, and we're asked, as doctors to say, classify, tell us where this tumor came from. And we have seen some differences in how patients respond depending on which bile duct the cancer actually originated from. We've been taught that gallbladder cancers, tumors tend to shrink quicker, extrahepatic bile ducts, also fairly good. Intrahepatic bile ducts, for some reason, they don't shrink as much, but they can just hang out there for a little while. We've seen some differences. And also for billing and coding purposes, they tend to ask us to define exactly where all this came from. So what do these bile ducts do? They're really just like 4 or 5 inches long tubing, basically. As far as I'm concerned, that's what it is. And their job is to carry this bile that is made inside the liver, take it out, and deposit it into the small intestine. Really, that's kind of the most function that they really have to do. And think of the biliary system as a very efficient recycling system. When you think of bile being produced, there's about 30, 40 cc's of bile being produced every hour by all of the liver cells. But if you take a 24-hour collection of bile, when somebody has a tube outside, they can make as much as a liter of bile. So really, in our body, we have about 800 ml to about a liter of bile. But thankfully, the body doesn't need to get rid of all the bile acids. It efficiently recycles and reabsorbs 95% of the bile acids. So the liver is really only making 5% per day extra, which is what you lose in the stool. And thankfully, because the body can recycle this and bring those lipids, the bile acids back in circulation, you don't end up losing a lot of these bile acids. So what is bile made up of? Bile salts, 60% of that. There's bilirubin, some phospholipids, a lot of it is cholesterol, and some fatty acids. And this is just a little diagram of how this recirculation and recycling goes on. So in addition to that little bile acid that the liver cells make, the other things that are sort of secreted or thrown in from the bile duct cells are these electrolytes, and they carry charge. I'm not very good in math or electricity or anything, but I just know that when there's charge, things move. And that's what happens. There's a positive charge, a negative charge. These ions kind of drive the bile and they help it move. And that's important to know because without that, the bile wouldn't flow very well. So I guess I went over a lot of this already. And these liver cells that make the bile, the place that this happens is a junction where there are liver cells as well as bile duct cells. And there are some patients who do develop liver cancer as well as bile duct cancer. We call that mixed hepatocholangiocarcinoma. And I just mentioned that because when there are inflammatory conditions that affect the liver, sometimes those same inflammatory conditions also can cause bile duct cancer. And overall, because of this recirculation and there being very little of this excreted in the stool, for the most part, very small amounts of this bile acid or bile secretion has to occur in the urine. But now we come into a disease state. What happens when there is an obstruction? Obstruction can cause basically infection because when all of this flows and connects to the small bowel, that's where we have gut flora or germs, bugs. They're supposed to be there. But once you have an obstruction and you don't have flow, think of it as even in your backyard. If you just have stagnant pond of water, things will grow in it. And so when things are not flowing very well, there's a greater risk of infection, which we call ascending cholangitis, and that's been the focus of this biliary emergency card endeavor and project that we have done. But what other things besides cancer can cause obstruction? Gallstones can cause obstruction. Strictures, meaning chronic inflammation, can cause things to get a little tighter and the flow is not very good. So sometimes they're not from cancer, they're just benign, or possibly from some old surgery that you've had. So there are other things that can slow the bile. There are also some genetic conditions, one called primary sclerosing cholangitis. And in those conditions, in that particular condition, the bile ducts, sclerosing means making scar tissue. So these poor bile ducts, they're not as wide and as good as they need to be. They have developed patches of inflammation and they're narrower, so bile doesn't flow. It's kind of like having an obstacle course going on. And that's partly why the liver gets chronic inflammation and develops cirrhosis. And in those patients as well, there is a higher risk of getting biliary cancer. Unfortunately, a lot of those patients tend to be younger because this starts pretty early in life for them. And biliary atresia. So this is when we were looking at that embryology picture where things were supposed to rotate and they didn't rotate right, something didn't happen right. Then you have bile ducts that are not formed properly, and that's why there's a problem. And all of these things cause people to get obstruction. So intrahepatic, all of this, like bile duct obstruction applies mostly to the extrahepatic or Iyer cholangiocarcinoma. Although intrahepatic cholangiocarcinoma can also do this depending on the location, bile ducts inside the liver, when they form cancer, many times you don't find the cancer until it gets pretty big, because they don't often come to you with the jaundice until it comes more to the center where it's blocking the bile flow. We really can function with half our liver, really actually even 30% of our liver, which is why people can do liver, donate liver for liver transplants. And that's why patients say, why did I not get diagnosed? I went to my doctor all the time. And this is why, when you look at this mass inside the liver for this particular patient with intrahepatic bile duct cancer, until it hits the capsule and stretches the capsule and the patient has some pain, they don't go to the doctor. And it takes a little while for all of this to manifest as abnormal liver function tests. Extrahepatic bile duct cancers, as I mentioned, perihilar and distal, are distributed between 60% being higher up and about 20% being more distal. And that is where some of the challenge lies. You've heard many times patients say, I was diagnosed, but it was not possible for them to cut it out, because at the perihilar region, this is very tricky. They can't go and cut it all out unless they have a way to tie this all back to the common bile duct. And that makes it challenging to operate on. The distal ones, if they're found in time, people can have surgery, the Whipple procedure usually, and then they can do pretty well. And this is just a little cartoon to show you how the bile duct looks when there is cancer and it's all strictured up. And you can see how bile wouldn't be flowing very well through that particular tube. It really looks very narrow. So when patients go for a scan and they look at the picture, this is just another cartoon to show you how, when there is tumor in there, how narrow it gets, inside of the bile duct. The CAT scans will show us that there are wide bile ducts or dilated bile ducts above wherever the obstruction is, because the bile has nowhere to go. So it's sort of stretching out and accumulating up there. And that's kind of something that we also see at a CAT scan, and we start to worry that there is something in there. Why is this bile duct getting wider? And it takes us a little time to figure out how to get to it to get a little biopsy. So where are we suspecting that something is wrong with somebody's bile duct, that there might be cancer? These are all our risk factors that we know of so far. Primary sclerosing cholangitis we know of. Parasitic infection, you'll hear more about this tomorrow, some toxins, some congenital anomalies, and all kinds of inflammatory conditions that are listed over here. Some patients also have benign conditions, a benign stricture, and from having it from a long time, sometimes that can also lead to cancer. So when someone has a bile duct obstruction, what happens to them? Most of them come and report that they are jaundiced. Some of them report that they have pain. Some have dark urine. Their stool looks lighter. The bilirubin, the bile, is what makes the stool the color that it is. If there's no bile in there, then it's much lighter. It's like clay colored. And patients sometimes have a fever, they might feel itchy, nauseous, vomiting, feeling tired. We already heard Melinda's story. Pretty much she hit like 80% of those things. And why does this yellow discoloration happen? Normally, when bile is excreted and it's flowing through the stool, there's none of it in the urine. It has a path. It knows where to go. But if it doesn't have a path, it doesn't have a way to get out of the system, then it gets back into the bloodstream and the body says, get rid of it from somewhere, anywhere, wherever you can get rid of it. So it accumulates in the eye, the skin, the urine, and that's why you see this yellow discoloration. And how do we diagnose this? What do we start off doing? You might have heard of and had yourself a blood test called the CA19-9, and that can sometimes be elevated in obstruction as well as in cancer. So we have to see when it was drawn and how obstructed the bile duct was at the time. And ultrasound is often the first place where we start to see if there's something wrong, because most of the time we're thinking gallbladder, gallstones, very similar. That's the first thing that comes to mind, for the primary care doctor. And then combining that with some endoscopic ultrasound, we can often get a biopsy. So what are the typical tests that you go through to make this diagnosis? A CAT scan is the usual one, and we're looking to see where it is located, how far it has spread, something called staging. And for many patients, they often start by getting an ERCP, where basically through the mouth, they go into the stomach, into the duodenum, to the point where they see the bile ducts exit. And through there, they send up a wire. They see where little green bile is flowing, and they send up a wire and they see, can we get up into where the ducts narrow and finally get wide? And then before they go in, that's why they ask you for a CAT scan or an MRCP, so they know how long of a stricture or obstruction there is, so they can plan the stent accordingly. And if they're able to get past that obstructed area, they're successful. They go in and try to put in a stent. But initially, when you're getting this procedure more for diagnosis, they try to get some scrapings and try to get a biopsy to make a diagnosis. Other tests that could be done include a PET scan or a PET CT and an MRI. Sometimes people have cirrhosis or some other conditions and they're not sure, so sometimes the MRI can be the better bet. But what is our first job when we hear or suspect there's something wrong with the bile duct is to confirm that there is cancer. We don't want to call something cancer when it's just inflammation or it's a stone. So getting a biopsy and getting something like this to the pathologist to confirm that it is not normal is the first step. The second step is to stage. How far advanced is this? Where is this exactly? And simplistically speaking, because there are different classifications for intra-perihilar, extrahepatic cholangiocarcinoma, and gallbladder, simplistically speaking, stage 1 is when cancer is in one spot and usually can be removed. 2 and 3 are when it's a little bit bigger and it may have affected lymph nodes or it's so close to some other important organ that we're not maybe able to take it out. And stage 4, when it's really moving through the bloodstream and it's going to other spots. And that's usually not what anyone wants to hear, but that's where we start, because if we don't know where it is, how would we know what's the best treatment plan of attack? So this is the maybe one take-home message besides knowing what bile is and what bile ducts do, is that you really need a team. And this is why. To confirm the diagnosis, you need a pathologist, you need a radiologist or a gastroenterologist to go get that little piece. Some primary care doctor or emergency room doctor suspected it to begin with. And if you're obstructed, unfortunately, then someone has to go in and relieve that obstruction so that the bile can flow normally. And that's either done with an ERCP or something else called a PTC. And they've done several studies showing that when patients have surgery, after relieving the obstruction, they have better outcomes. And in addition to that, the next step is, can we cure this person? Can we cut this out? Because that's what everyone wants to hear. Just take it out, just take it out. And for that, we need to know where it is, but we also need to know what the overall health of the individual is. If someone unfortunately had a stroke a month ago or something, that's not the time you want to be having such a big operation. So medical management, meaning treatment of the cancer with chemotherapy or looking at a clinical trial, which some of you or many of you may have looked into or explored, getting another opinion. And those are the things that a medical oncologist would do for you. And palliating symptoms, sometimes a palliative care expert gets involved, sometimes a pain team gets involved, And sometimes all of the doctors above get involved to make someone feel better. So one of the procedures that people have gone through, just to simplify it and see what the bile duct looks like after you've had a stent placed, is that ERCP scope that goes up through the duodenum with this little wire. And when they're up there, I just wanted to show you what a plastic biliary stent looks like and a metal biliary stent looks like. As you can see, the plastic biliary stent is much narrower. It's kind of like a Starbucks coffee straw. It's pretty small. And the metal biliary stent is much wider, much bigger. And I've had patients ask me, why don't they just put the big one to begin with? And we explain to them that sometimes when the doctor is in there and he's looking, everything is swollen and inflamed. It's not easy, as you can see in that particular picture, it's not easy to know which direction I'm going even. And also when they don't know what the care plan is going to be, is this person going to need surgery, not? They start off with just sticking something narrow in there and relieving the obstruction for now. And as the swelling goes down, the care plan is made, diagnosis is confirmed. Sometimes people have had chemo for a little while, things shrink up, then they can go and upsize and put something a little bit bigger. But as you can imagine, this is plastic and it doesn't last forever, and these stents do need to be changed every 2 to 4 months. Sometimes the doctor goes in there and tries to do the stent, and he just can't because it's too tight, and he can't be just jabbing wires up there, not knowing where this wire is going. And so they come back and they say, I'm sorry, I can't do this for you. Or if the patient has had surgery before and their anatomy is all different, they say, we can't do this for you. And then in that case, we have an interventional radiologist find a way to put the tube from the outside into one of the bile ducts and relieve the obstruction that way. Not fun. We've had some patients who've even needed 2 and 3 of these tubes. They have even said, I feel like a Christmas tree. I don't like this. And we go, I know. But when we start the treatment, there's hope. We can shrink the tumor and sometimes get rid of them down the road or internalize it. There are also patients who've had surgery to relieve biliary obstruction. The Whipple procedure can sometimes be done suspecting cancer, and most of the time it is. And there also are some palliative surgical procedures where they can, if all of these other approaches don't work, take a little loop of bowel and bring it up there and try to relieve the biliary obstruction that way. So I'll end with just whatever happens to the bile duct. As you can see, keeping the flow is critical. Our goal ultimately is to get to chemo or radiation, start off with antibiotics if something looks infected in there, find a way to drain this bile and keep it flowing, and also make people feel better, because all this obstruction doesn't make people feel very good. It's kind of like, I don't know, traffic jam, kitchen sink clogged. You just don't feel good. So all of these are our kind of challenges to make you feel better. And always we're looking to see whether there's something bigger or better than what we currently have, like trials, immune therapies, targeted therapies, and you're going to hear all about those options to help keep this bile duct open and working in the next hour. So with that, I will end and take any questions. Thank you.
Dr. Iyer, hi, Rick Pollack back here at the back. Tara Swaby emailed in with a question. Her father just passed away from cholangiocarcinoma, and she's concerned that she's wondering if there's a hereditary or genetic component to cancer, and more specifically cholangiocarcinoma, and if there are any types of screenings she could do now to see if she's at risk.
Well, thank you for the question. I'm sorry for your loss. I know that it's not easy to dial in and still be here and listen to all this, and especially when it's so new. So the question is biliary cancer hereditary? So just simplistically speaking, genes that help cells grow and divide and stay alive are called oncogenes. And genes that slow down cell division are called tumor suppressor genes. And sometimes there are small alterations in DNA that basically turn on oncogenes and turn off tumor suppressor genes, which means there's nothing stopping something from growing, and there's actually something that's stimulating the cell and making it continuously grow unchecked. And that sort of is what we worry about when we say, is there something genetic that's making this cancer grow? Unfortunately, we don't have a very good enough inventory of studies. The group at Mayo Clinic is trying to study the genetics of biliary cancers, and several other groups are as well. We just don't have enough data to tell you that there is a screening test or something that would benefit you. But they have done studies and found genes like P53, which is a very common tumor suppressor gene, KRAS, HER2, MET, and many cancers are also just from inflammation. So as far as we know, if patients are aware of having hepatitis or any other inflammatory condition, gallbladder, stones, or something else, those risk factors can be monitored for. But other than that, for now, I'm not aware of anything else to offer her.
Louis, you would like to maybe just comment a little bit because it's part of your work.
Thanks. Yes. So, and I think Dr. Iyer is really very accurate in that we are really in the midst of this. One of the challenges is that we have a cancer that is uncommon, and consequently, there are relatively few samples available from patients with the cancer. Typically, what we do with these types of studies is we take samples of what we call the blood DNA or the germline, so the DNA you were born with. So not necessarily, you'll hear lots about studies we are doing on the tumors, studying what's in the tumors that's causing them to grow. But also, this question about genetic predisposition really refers to what was I born with that might be making me at risk of down the line developing a biliary tract cancer. So when we have individuals who have bile duct cancer or cholangiocarcinoma, we want to take blood samples of their blood DNA and then compare that to blood samples from individuals who have grown to middle age typically, but have not developed cholangiocarcinoma. And then compare those DNAs from the different individuals and see, are there changes that we see in people with cholangiocarcinoma that are occurring more frequently in their blood DNA than people who don't have cholangiocarcinoma. So if we think, for example, about breast cancer, many of you have heard about the BRCA genes, the BRCA1 and 2 genes that have been associated with inherited predisposition to breast cancer. And really that's what we're hoping to do. Our initial quest is to get DNAs from about 2,000 individuals with cholangiocarcinoma. I think we are right around 1,700, 1,800. I think there'll be a poster here tomorrow that shows where we are. And so we are really actively encouraging individuals with the cancers to collaborate with us in this study. And actually, if you go to the Cholangiocarcinoma Foundation website, there's a call for participation there. And so we're really wanting to encourage people to participate as much as possible.
So to help translate all of that in English one more time, so what Dr. Iyer tried to say is that, well, it's over my head as well, to be honest with you. So what Dr. Iyer is trying to tell us, and this is very important, there are certain inherited diseases that might lead to cholangiocarcinoma, but at the same time what Dr. Lewis is telling us that we don't have yet an evidence of an inherited form of cholangiocarcinoma. So to answer the question, no, not yet. We're working on it. Yeah. Okay. All right. Good. Any other thoughts, questions? Yeah, please go ahead, Dr. Garcia.
There's a new technology that has come out called CRISPR genome editing, and they're doing some work on various diseases such as removing the portion of the HIV on those people chronically ill with HIV to affect a cure. And I understand that that's in the works. Is any of this work been done to remove those mutations on patients with cholangiocarcinoma through the CRISPR genome editing?
Anybody would like to comment, or shall we hold off on that until later so we understand what exactly we're referring to? If we can try to focus on, what the subject matter here, I think there are questions. We'll get back to that in a second.
I believe you had mentioned parasite infection as a risk factor. What are your thoughts on uremic syndrome? E. coli causing that, potentially?
I'm not aware of a risk factor.
Neither am I. Not really. Yeah, these parasites, by the way, we have Dr. Subang tomorrow meeting us from Thailand, and he will talk specifically about the parasitic infection, which mainly happen in Southeast Asia, specifically in Thailand, Cambodia, Laos, and Vietnam. We don't really see much of it in the US. Yeah.
In
Yeah.
diet, there is this
Yeah.
liver fluke that kind of has a predisposition to go and kind of hang out in the bile duct, if you will, and it causes inflammation, and you'll hear more about exactly how that happens.
Any other thoughts? Yeah.
Is there a change in the distribution of intrahepatic versus extrahepatic versus distal? If you read Wikipedia or wherever you look online, it talks about I think extrahepatic being more common than intrahepatic. I know the patient population here is probably 90% intrahepatic. Maybe that's a factor of the aggression, or the aggressiveness of the disease, and intrahepatic people survive longer, et cetera. But I don't know if there's anybody tracking those trends and updating that information somewhere.
So we'll let Dr. Roca probably comment on that, or either of you, just kind of like show us the epidemiology.
Notice
of
how
disease,
many
yeah.
helpers I have.
Yeah.
Like,
I
just
offered, by
saying,
the way. I offered,
the
but
girl
she said
can't do
no.
it.
So I said, we're like playing volleyball here. So
I think it's actually been quite interesting and somewhat concerning that we are seeing time trends in these subtypes. And I think probably the most dominant trend is that in most industrial countries, it appears that intrahepatic cholangiocarcinoma is going up. And we did a study a few years back where we tracked back about 30 years. And in the county that Rochester, Minnesota is in, we found a 7-fold increase in intrahepatic cholangiocarcinoma going back 30 to 40 years. So definitely that observation that has been made in a number of industrial countries seems to hold up.
follow on that question, though, what's your view on what actually Renuka referred to as well, which is the unknown primary, now that we understand cholangiocarcinoma? Is it like really now we understand better the disease, or is this really a real trend?
Yeah, so there may be some of that, but I think that's the advantage of being able to be in one where in our county, for example, we're able to assess everyone and look at everyone's records very carefully. And so it seems like even after you adjust for the idea of these cancers of unknown primaries, there's still an increase that we're seeing.
So just to clarify, liver cancer has one diagnosis code as far as we all are concerned in what we do in our coding. I don't know the ICD-10 code, but the ICD-9 used to be 155.1. And so liver cancer, hepatocellular cancer, and intrahepatic cholangiocarcinoma carry the same diagnosis code. And while hepatitis prevalence went up, and we have more and more people with chronic hepatitis C, alcohol use, NASH, non-alcoholic steatohepatitis, and the risk of hepatocellular cancer going up, we think the intrahepatic cholangiocarcinoma risk has also gone up, but because we code them the same, we can't distinguish them very easily. And that's where work that Lewis is doing and their group is doing, where they're carefully looking through those pathology reports and saying, who is actually hepatocellular in this, who is intrahepatic, what went up, what didn't go up. That's kind of what they're talking about, to know what is the true trend. And the other part about unknown primary, when someone shows up in my clinic and says, there's a liver mass, the billing coding people call it unknown primary, liver metastases, 199.1 diagnosis code. Figure this out. You go see what it is. And 85% of those cancers end up coming from somewhere else. It was not a primary of the liver, it came from somewhere else. And those cancers we call carcinoma unknown primary to start off, but somebody has to go back after we've looked and found nothing anywhere else for the 15% that truly started in the liver and can have surgery, potentially cured, et cetera, and go recode them and say, no, now this is intrahepatic cholangiocarcinoma. And so until that happens, there is a little bit of lost data, There are some who went away as unknown primary, we didn't track them or catch them. Some got counted as hepatocellular, we didn't know exactly who those people were. And I think there are just some people who still get told you have a liver tumor, and they still don't know what they're being treated for. They just get treated with a blanket chemo. I worry sometimes that still happens a little bit. So that probably explains this. It was a good question, though.
Thanks.
Thank you.
Any other questions? Yeah, please.
I'd like to know if you can tell me what the percentage of patients, cholangiocarcinoma patients are that have PSC. Are there stats?
Of the PSC, of the patients with PSC, about 25% get
So
cancer.
PSC is primary sclerosing cholangitis for those who are not necessarily so, yeah.
So of the patients who have PSC, 25% get cancer in their lifetime. But of all the biliary cancers, the proportion that actually are from an inherited condition are like less than 2%, some very small proportion. They're not a big number.
I would like to actually add a comment because you kind of nicely illustrated it in regard to the biliary stents. And obviously, what Dr. Iyer was trying to explain, that biliary stents are necessary for obvious reasons when there's a blockade, and try to reduce the bilirubin, because the bilirubin is very important to be at a certain level to allow us to treat, because the metabolism of the liver will depend on that, so we don't get toxic while getting therapy. But however, obviously, it wasn't. It was a very clear illustration about the necessities and how many tubes you might need, but it was not, and to be very clear, an invitation in any way, shape, or form to kind of go with endless tubing. This is a very complex situation that some of you probably, or loved ones, or those who are following us, probably have to deal with, which is kind of like, how many tubes? Remember one thing, it was also alluded very nicely to, the biliary tree is totally sterile. The minute you pierce through it, we infect it. And in other words, this becomes a nightmare of infections if we really don't have a certain set goal. So kind of like when we're kind of like now digging into 3 tubes and draining right and draining left liver and draining central liver, this is where kind of like a bigger discussion has to happen. So it wasn't in any shape or form any invitation to say, okay, like the more the merrier and we can get therapy. We have to put this in perspective. I want to make sure that we push on that specifically. All right, good. Any other thoughts, questions? Okay, good.
Thank
All right,
you.
very good. Thanks
Thank
so
you.
much. Thank you.